And I think we can adopt and adapt some of the suffering during the pandemic, like the incident command structure, the daily huddle, following a guideline. Wouldn't it be great if we could kind of take those lessons forged like in combat and then get those lessons deeper into the system? The daily huddle, following a guideline, closing the feedback loop, and giving people information that they could act on. Just to check in the box is not going to do it. Money for ongoing education. Well, we have people furloughed, so now we're faced with some terrible choices as to how to allocate resources from a leadership perspective.
So let me ask a follow-up question on that. So we're hearing that a lot, that the healthcare executives are saying, listen, it's going to be really hard. I appreciate the insights we're getting from NAHQ. We've got to really figure out how to prioritize and how we're going to make these improvements when we're furloughing people and we have these hard economic challenges currently and even ahead of us.
We better be careful, because the bricks and mortar, we could be at risk if, this could be what folks have called, the Amazon moment for healthcare. It has deep implications for the quality, safety, and pop health movement, no question.
Well, and to your point about those companies that are getting together and trying to build a better mousetrap and head in that direction, when I think about it, and what they're trying to do is a lot of innovation and quality training and development. And I asked him, why are you doing this? And you do a lot more than other groups do. And he told me, he said, Stephanie, it's because hammers don't build houses. And so I love that, because, people do quality. It's not going to be a technology alone. It's not a consultant. It's not a buzzworthy trend. People deliver healthcare. And so I think the competencies are always going to be needed.
So let's go back to my Teladoc Livongo example. So what are the quality measures of the care that they deliver? Well, that's an open frontier at the moment, right? Amazing.
Well, and also too, I think just from a telehealth perspective, when I take a look at that, I think, how much time and energy and heartache we have all spent trying to reverse engineer a lot of the ways that the work gets done in healthcare delivery today.
Exactly.
Telehealth has a clean slate. I look at that and say, oh my gosh, this is it. We could start from the beginning of this thing and really focus on quality and safety and value with telehealth. So
it's a great frontier, a great opportunity for NAHQ and NAHQ members.
High healthcare spending doesn't necessarily equate to high quality care. What I wanted to illustrate to you today is, what this is going to do in terms of the healthcare industry and the move towards value-based payment. I anticipate in the next 12 months, and this is backed by research from countless thought leaders in our industry, but there will be an accelerated transition to value-based reimbursement as we look to resolve some of the ongoing issues in our health system. The promise of tomorrow is really payment reform, which is going to cause delivery reform, workforce development. This goes back to the great work being done by NAHQ, and then how we can leverage that appropriately to achieve the triple aim. And if you think about it, the quadruple aim, how can we resolve some of the moral injury in place in our healthcare industry by really reforming and transforming our system today? It's more likely that your credit score or your zip code is going to impact your health more than actually seeing a provider. And that has to change by providers in the healthcare system really looking more holistically on how to deliver better, more effective, cost-efficient, value-based care. And that's going to necessitate workforce development. And that's where I commend the National Association for Healthcare Quality in creating a competency framework based on 29 competencies, 486 behaviors, 8 dimensions. They've spent years thinking about and mapping all the necessary skills needed to succeed in quality improvement. Again, quality improvement touches all facets of value-based payment. There's clearly a need for a competency-based framework. And I think so highly of what NAHQ has done in this space, and certainly I would expect there being more to come in this conference, learning more about the plans to really make scale and impact happen for the workforce of tomorrow.
So what we've learned over the past few years is that the most important thing is to hardwire standard work. That's the only way we would get to our goal of zero harm by 2026. So what is standard work? Standard work is defined by our providers and our clinicians on the front line. It's the standard of care that we want all of our patients to receive, regardless of whether they're at our tertiary hospital or whether they're at our critical access hospital. And basically what we did was we created what was called promise packages that would allow us to demonstrate to the frontline staff what the best practices were and how do we implement that. So from 2016 through 2019, we had a 62% reduction in hospital-acquired infections. That translates to 276 people who did not get infections because of the promise packages that we launched. And it's always important to remember that it's about the patient. So we use this as a visual reminder to all of us why our work is important.
Collaboration is hard work because in order to be effective at it, you really have to work at breaking down silos, bringing new and different voices to the table, putting aside your own agenda and listening to what others are saying, and then coming to consensus in order to get to the key results. This human-centered design approach really is one of the tools in the toolbox. You know, we have many tools in our quality box, whether it be lean or using agile approaches to designing our systems, to human-centered design, to whatever tool that you have available. This is one of them. And where you go out and you really look and you hear and you do using a process that's fairly well defined. It's been used in software development for many years, but now finding its way into policy development and other kinds of things, of really interviewing, observing, listening, watching for the pain points, doing journey maps to look at the journey, and then taking action based on that. So what? That's a question we ask ourselves a lot, and I encourage you also, as you're putting together your data or presentation, going to your boards of director, ask yourself, so what? And then having an answer. So in our so what, when we looked back, we were able to show that in one of our initiatives of the Partnership for Patients, 20,000 lives saved, 7.7 billion in savings, and 910,000 fewer harms.